Friends, I'm Dr. Deven, Juneja, Director, Institute of Critical Care Medicine, Max Super Specialty, Saket. And I invite you all to attend another session of STEP Nursing, organized by Indian Society of Critical Care Medicine and Indian College of Critical Care Medicine. The topic for today's lecture is hypoxia and/or respiratory distress in ICU patients. And the speaker of the day is Dr. Saurabh Taneja, who is a very close friend of mine and a great academician and clinician. And he is senior consultant at Institute of Critical Care and Emergency Medicine at Sir Gangaram Hospital, New Delhi. So over to you, Dr. Saurabh. Can you please change the slides?
I'm trying to share my slide, just a second.
Yeah.
Yeah, can you all see my slides?
Not yet.
Yeah?
No, Dr. Saurabh, we can't see your slides. I think you will have to stop this sharing first.
Yeah, sorry?
Somebody is sharing the screen.
Yeah, I am trying to share the screen, but the slides are not visible, I guess.
So please share it again.
Can I send it to one of you? Because I don't
Yeah.
think.
Yes,
Yeah,
sir.
please
Please
do that.
send me mail on education@icesystem.org. Then
I
I'll
will.
share.
Yeah, I sent it. Yeah.
सर आप स्टॉप शेयरिंग करिए. We can start,
Thank you
sir.
so much. Am I audible?
Yes, sir, you are audible.
So, thank you ISCCM and Indian College of Critical Care Medicine for giving me this opportunity to have this step session on hypoxia and respiratory failure in ICU. And I would like to thank Dr. Deven Juneja, who is a very dear friend and mentor, for introducing me. And we'll be talking about hypoxia and respiratory failure in the ICU. Yeah. Next. So how we'll see a case-based discussion. We'll talk about management of hypoxia. We'll talk about what is respiratory failure, what are the modalities in the treatment of respiratory failure nowadays, and we'll have few MCQs that will make you keep attentive in the between. Yeah. Next. So we start with the case. A 52-year-old male is a known case of hypertension and type 2 diabetes. Vaccination status not up to date with influenza and COVID boosters. He is accounted by occupation and he has a smoking history for 20 pack years and he has quit 5 years ago. So the typical case that presents to us, and the initial presentation was that shortness of breath and high grade fever for 4 days. And the patient had productive cough and generalized myalgia. So this is a typical symptomatology that the patient presents to us. The most common presentation are fever and shortness of breath coming to the critical care settings. And the patient had productive cough and generalized myalgia. When we look at the vitals, the temperature is 38.8, so he's febrile. He is having tachycardia of 112 beats per minute. The respiratory rate is 28 per minute. BP is 134 by 86, and saturation is 84% on room air. So he is hypoxemic, and he is febrile, and he is tachycardic. Yeah, next, please. So when this patient presents to us in the emergency or in the ICU, how will you manage such a patient? So initially, we want to maintain the saturation of more than 92%. So we supplement it by initially by nasal cannula. If the patient requires more oxygen, we go to higher alternatives. Since the patient is febrile, is tachycardic, we give a IV fluid bolus. And since we suspect that this is a patient of sepsis, we start with broad spectrum antibiotics as soon as possible. And we send for some investigations. So what investigations do we send? The initial ones are the lab parameters, which is the CBC, the RFTs, the serum electrolytes, and we look for any infective workups like CRP, procalcitone, and all the cultures. We do a chest X-ray because the patient's symptomatology tells us that the most common involvement in this patient must be of the chest or a lung parenchyma, and we do a blood gas analysis immediately. So when we do a blood gas analysis, it showed mild hypoxia with respiratory alkalosis. Yeah. Next. So when we talk about what is the importance for the nursing, so when such a patient comes to you in the emergency or it comes to you in the ICU, so what do we do immediately? We measure all the vitals. So what do you mean by vitals? We measure the heart rate, the blood pressure, we look at the skin, we look at the temperature, we look at the saturation. So anything that we find which is abnormal in this case for the patient was tachycardic, he was febrile, then he had a saturation of 84%. So we try to manage this side by side. So we'll supplement oxygen so that the saturation levels are more than 92% at least. We'll give a fluid bolus so that the tachycardia settles down. We'll give an antipyretic to make the patient comfortable. Then we'll send for the blood cultures and then the sputum cultures, gram stains, so that we find out what is the infective foci to treat such a patient. We secure IV access immediately and we attach the monitors as soon as the patient comes to us. And we should be in close communication with the family of the patient, with the attendants and the doctors in this case. Yeah, next. So this patient was unable to maintain oxygen with nasal cannula. And when we are at the emergency, if we try nasal cannula, we give the FiO2 of around 0.24 to 0.44, that is 24 to 44%. we straight away should move to a non-revision mask. The idea is firstly to have a normal saturation of more than 92%. So we escalate to non-revision mask, and on that the patient maintain the saturation. So we'll be talking about a bit of hypoxia. Next, please. Next slide. Yeah. So this patient was hypoxemic, and we'll be talking about hypoxia here. So hypoxia is a condition in which there is insufficient oxygen available to the tissues to maintain normal physiologic function. And when we say that, we should know what is the normal PaO2 or arterial oxygen. So normal is between 80 to 100, and hypoxemia we say when it is less than 80, and this is defined for room air. And normal saturation, when we measure our own saturation, it is around about 95 to 97 to 98% usually. Some of us may have 90 to 100%, but normal is 95 to 100%. So this patient had a saturation of 84%, which should raise the alarm. And we check for the saturation waveform on the monitor, and the waveform is fine. That means the saturation of 84% is genuine, and we want to connect this patient to oxygen immediately. We have to supplement oxygen immediately in such a patient so that his saturation should be maintained at more than 92%. Next. So these are the ABGs. When we say a blood gas analysis that we do, we should know the normal values. It is very essential for the nursing to know the normal values, for all the doctors who are handling the ABGs to know the normal. Each one of us should know the normal values so that whenever we find an abnormal value, we should raise an alarm. So the pH is normally 7.35 to 7.45. The PO2 is 80 to 104, as I told you, 80 to 100. The PCO2 is 40 millimeters of mercury. The bicarbonate is 24 plus minus 2 milliequivalents per liter. The base excess is plus minus 2. The oxygen saturation is 96 to 98%. Yeah, next. So electrolytes are very important. The sodium normally is 135 to 148. Potassium is 3.5 to 5.5. The calcium is 1.13 to 1.32. The chloride is 98 to 106, and the ion gap is 12 millimoles per liter. So when we do a blood gas analysis, we see a pH, we see the PaCO2, we see the PaO2, so that will define a respiratory failure. Then we look for the metabolic parameters like bicarbonate, whether the patient is having metabolic acidosis or not. Then we always look at the electrolytes, the sodium, potassium, calcium, and chloride, and the anion gap. So this will tell you when sometimes what happens when the patient comes to us, he or she is suffering from multiple comorbidities. It is just not only that the patient is suffering plain hypoxia. The patient can be a long-standing COPD patient having multiple medications. The patient can be a CKD patient who's on multiple parameters, who may have dialysis, who may be on CAPD. So all the metabolic parameters and electrolytes can be haywire. The patient can be having a fever for a prolonged duration of time for 3-4 days. The patient may be strictly dehydrated with hypernatremia. The patient, the oral intake may be less. So the same patient can come present with hyponatremia. So each and every patient's clinical history should be taken into account. Family should be talked to. It should be communication should be there, and then these ABG parameters or initial lab parameters should be judged accordingly in accordance with the patient's history. Next. So when we talk about hypoxia, we should know how the oxygen is being carried out in the blood. So we all know there is a hemoglobin in which actually makes oxygen travel, or which actually binds to oxygen. So each molecule of hemoglobin can carry 4 oxygen molecules, and 1 gram of hemoglobin can carry approximately 1.34 milliliters of oxygen. So when we talk about content of oxygen in the blood, so content is the total oxygen that is carrying in the blood. So it is dependent on hemoglobin. If you see the equations, content of oxygen in the blood is equal to 1.34 into hemoglobin into saturation plus a dissolved fraction of oxygen. So hemoglobin and the saturation are the two main parameters that are very important when you talk about content of oxygen in the blood. So if hemoglobin drops or the saturation drops, this patient's oxygen content will drastically drop. Next. There often we define what is hypoxemic hypoxia. There are 4 types of hypoxia. We'll talk about all of them in a bit of detail. So when we tell hypoxemic hypoxia, the name itself is very clear. So although hypoxia is there, but the hypoxia cause is hypoxemia. That is due to low arterial oxygen tension. And it can be due to high altitude. When we move on to higher altitudes and the Himalayas and the base camps, we realize that the partial pressure of oxygen in the atmosphere itself is lesser. Then there is VQ mismatch like pneumonia or ARDS. shunt, and impairment of diffusion. These are the other parameters. So most common is the ARDS or pneumonia that we find that there is a hypoxemic hypoxia. Right? Then we talk about anemic hypoxia. So we realize that the hemoglobin and the saturation are two important parameters. So if hemoglobin is low, that means in spite of normal oxygen PaO2 in the arterial blood, but the overall oxygen carrying capacity is decreased. And this happens especially in anemia or methemoglobinemia, when the hemoglobin is not normal and this cannot carry 4 molecules of oxygen. Okay. So circulatory or stagnant hypoxia. So now we know that the hemoglobin content is fine, the PaO2 is fine, the saturation is fine, the hemoglobin is fine, so oxygen content is fine, but there is one circulatory hypoxia. The blood flow is inadequate to the tissues, and the cause can be vascular occlusion, which can be a direct occlusion to a limb or more than one limb, or shock. So all of these things can lead to circulatory or stagnant hypoxia. Next. Then histotoxic hypoxia. So the oxygen content is fine, the blood flow is also fine, but what happens is a mitochondrial dysfunction and the issue is with the oxygen utilization. So the cells cannot utilize oxygen, and this is most typically seen in cyanide poisoning or some bit of mitochondrial dysfunction in severe sepsis. Next. So this is a table which tells you what are the 4 types of hypoxia, the major causes, and how will you distinguish or so hypoxemic hypoxia. We know that although the perfusion is normal, we have low arterial oxygen and thereby low oxygen content, and the most common cause is pneumonia or ARDS. In anemic hypoxia, there is low hemoglobin. In circulatory hypoxia, there is a shock or circulatory failure, and inside the histotoxic hypoxia, we have cyanide poisoning, in which although the perfusion is normal, the content is normal, but the cells are unable to use the oxygen. Next. So how do you distinguish between them? If you have a patient, how will you distinguish between them? So you rule them out one by one. You check the hemoglobin level, you can detect anemic hypoxia, you can check the PaO2, you can detect hypoxemic hypoxia. When you rule out this, there are 2 left, that is circulatory and circulatory that is stagnant, and histotoxic hypoxia. So lactate levels are increased in both of them because the end or the anaerobic metabolism is there and it is elevated in circulatory and histotoxic hypoxia. So when we do a mixed venous oxygen, it is low in circulatory hypoxia and high in histotoxic because circulation there is shock. So whatever oxygen is reaching the venous blood or the organ, it is utilized or taken out of the blood, and the mixed venous oxygen is lesser. But when we talk about histotoxic hypoxia, the oxygen is not utilized. So the bright red blood goes to the organ, the bright red blood comes out of the organ. The blood has oxygen, but it is not being able to utilize in the organs. Next. So when we take a blood gas analysis, when we send samples, when we deal with a patient of hypoxia, we know what are the types of hypoxia. So we try and raise the alarm if the hemoglobin is low, if the PaO2 is low, if the lactate levels are high, the mixed venous saturation, if we measure, is high or very low. So these are all the things we should think about. We should raise the alarm so that we are able to distinguish which type of hypoxia is our patient suffering from. Next. So coming to the first MCQ. And I would like all of you to write in the chat box the correct answer. So what is the most likely initial cause of our ARDS pneumonia patient's hypoxemia? So you can write in the chat box. The choices are A, anemia, B, diffusion limitation, C is VQ mismatch, and D is low inspired oxygen. So this is related to the types of hypoxemia. Anyone? Anyone? So next slide. Yeah. So the correct answer is VQ mismatch. So we told you that VQ mismatch or ARDS is one of the most common causes of hypoxemic hypoxia. That is what our patient is suffering from. Next slide. So in pneumonia or ARDS, the main cause of hypoxemia is ventilation perfusion or VQ mismatch and shunting due to alveolar filling. Yeah, next. So another question, and this will again try to distinguish between the types of hypoxia. And if you're able to do that, you'll probably understand the whole concept. Again, I would like all of you to participate. A 45-year-old factory worker is brought to the emergency department with confusion, normal saturation and PO2. normal hemoglobin levels, and bright red venous blood on the ABG. Despite supplemental oxygen, lactate remains elevated and the patient shows signs of metabolic acidosis. So what is the most likely type of hypoxia? Anyone? Which is the most common type of hypoxia this patient is suffering from? And the four choices are hypoxic hypoxia, anemic one, histotoxic one, and stagnant one. Answer please. Next slide. So the answer is histotoxic hypoxia, and we'll be saying why it is histotoxic hypoxia. Next slide. So what happens? The cells cannot utilize oxygen despite adequate delivery. So the hemoglobin is fine, the saturation is fine, the content is fine, the perfusion is fine. So all the points that want to deliver the oxygen to the cells is fine, but the cells by themselves cannot utilize oxygen. And this is often due to toxins that impair mitochondrial oxidative phosphorylation. And the classic example is cyanide poisoning, which inhibits cytochrome C oxidase in the electron transport chain, and thus the patient cannot utilize oxygen in this poisoning. Next. And as I told you, how we distinguish, we see there's a normal saturation, normal hemoglobin, bright red venous blood. That means extraction by itself is low and there's an issue at the cellular levels. And the possible clue in this case is the factory worker, that is possible cyanide or chemical exposure. So whenever you have a long MCQ with a lot of stems or a lot of hints, try to highlight all these things. The patient is a factory worker, there is normal saturation, normal hemoglobin, there is bright red venous bloods, high lactate. So this all points to cyanide poisoning, or there is issue with a histotoxic hypoxia. Next slide. So when we know that there is some bit of hypoxia, how we supplement oxygen? So this next step is, this patient came to you, you immediately put him on the nasal cannula. But even after having 6 liters of nasal cannula flow, the patient's saturation could not improve, and we had to put finally him on a non-rebreather mask. So we'll be talking about all the ways that we know how to supplement oxygen, that is nasal cannula, simple mask, non-rebreather mask, venturi mask, ambu bag, and a high flow nasal cannula. And we'll be seeing when we use these things. Next slide. So firstly, we distinguish between a low flow device and a high flow device. So what is the idea of low flow device? So the definition itself or the name itself tells it's a low flow. It delivers oxygen at a flow rate less than the patient's inspiratory demand. And high flow is delivers equal to or more than the patient's inspiratory flow. So low flow means that the flow is less, usually it is less than 15 liters per minute, there is no humidification. And the examples are nasal cannula, simple face mask, non-rebreather mask, in which high flow nasal cannula, venturi mask. So the logic is that the patient inspiratory flow demand is met in a high flow, it is not met in a low flow. So therefore, in the low flow device, it is entrainment of air, and the FiO2 that is actually being delivered to the patient is variable. So low flow devices give variable FiO2 to the patient. Yeah. Next slide. So the most common device when you use in the critical care settings or in the wards or in the high dependency units is nasal cannula. So it's a disposable plastic device with two protruding prongs for insertion in the nostrils. So there are two prongs, they are inserted in the nostrils and it is connected to the oxygen source. So we give oxygen from 1 liter to 6 liters in this, and if you give 1 liter, normally you or me breathe oxygen of 0.21 or 21%. So when we give oxygen at 1 liters, it is 24%, and with every 1 liter increase, it increases by 4%. So at 6 liters, we have 44% of oxygen that is being given via nasal cannula. So if even after that the patient's saturation is not being maintained, we have to move to a higher supplement or higher level of supplementation of oxygen by some other device. If we go more than, next slide please. So we should know the advantages and the disadvantages. The disadvantages are this can be nasal obstruction or dryness of mucous membranes when we actually give it at a more high flow rate, more than 6 liters per minute. It can cause skin irritation. So these are important things that we should know, that we should not go above 6 liters per minute in nasal cannula. It is uncomfortable to the patient. There is dryness of mucous membranes and there can be breakdown of the mucous membranes. The benefit is that the patient is able to talk. He can eat with a nasal flow of 1 to 2 to 3, 4 liters. It is very safe and simple to apply. It is very easily tolerated. And when we give a oxygen at 2, 3, 4 liters, it is very comfortable to the patient. It can even be used at the home. Yeah, next slide. So next is a simple face mask. So we give the oxygen from 35 to 60% and we try to maintain a flow rate around 8 to 10 liters per minute. So again, it is made of clear, flexible plastic or rubber that can be molded to fit into the face. So it covers the nose and the face and it is clear so that the patient does not feel any claustrophobia. It is held to head with elastic bands and some may have a metal clip which is over the nose. So nasal metal clip is there. And it is used when the oxygen requirement is slightly higher than nasal cannula. It can deliver up to 35 to 60% oxygen at around 8 to 10 liters per minute. And has vents on its side which allow room air to leak in at many places, thereby diluting the source of oxygen. That is why it can give only up to maximum of 60%. If the increased demand is there of the patient, even at 10 liters, the oxygen that is given to the patient will be less than 60%. Next slide. So this is how a simple oxygen mask looks like. You can see the nasal bridge, which is metal that is being able to hold and the straps. And there are exhalation ports and an oxygen source by which we give around 8 to 10 liters of oxygen. Next, please. So what is the advantage of a simple face mask? By the nasal cannula, we are giving around maximum of 44%. Here we can give up to 60%. When we put a tight seal, only then a higher concentration will be delivered with a higher flows. So it is not suitable for type 2 respiratory failure and it's uncomfortable for the patient while eating or talking. And when you put a tight nasal bridge, there are chances of skin breakdown at the nasal bridge. Next. So then we come to a partial rebreather mask, and this mask is the reservoir bag that must remain inflated during both inspiration and expiration. So when the reservoir bag is inflated, then only we can give a higher delivery of oxygen or a higher concentration of oxygen. It collects of the parts of patient exhaled air and the oxygen flow rate should be higher around 10-12 liters per minute, at least 6 liters per minute, to ensure that the patient does not rebreathe large amounts of exhaled air. The remaining exhaled air is exiting through the vents. Next. Obviously, it requires, so the higher the concentration of oxygen you want to give, you should have a tighter seal. And the client can or the patient can inhale room air through openings in the mask if oxygen supply is briefly interrupted. That is the benefit. It is not a closed system. The patient can inhale room air. Next. So non-rebreather mask, which was applied in our case, gives the highest concentration of oxygen up to 100%, 90 to 100% if you at a flow rate of 15 liters per minute. It is similar to the partial rebreather mask except to one-way valves. So when we have one-way valves, we will not allow rebreathing of the exhaled air and entrainment of the air from the room. So it is similar to the patient partial rebreather mask except two one-way valves present, which prevents conservation of exhaled air. So this also has a reservoir bag. So when the patient exhales air, the one-way valve closes and all the expired air is deposited into the atmosphere and not the reservoir bag. So idea is the reservoir bag is there, which has when we open to a 15-liter flow, the oxygen collects in when the patient starts to breathe in, the air is coming from the reservoir bag. And when the patient exhales, that valve closes and the exhaled air goes into the atmosphere. So patient is not breathing any of the expired gas or exhaled gas. That is why it can give a higher concentration of oxygen, but you have to open the flow meter to at least 12 to 15 liters per minute. Next slide, please. So it is suitable for patients breathing spontaneously with severe hypoxemia. But remember, you should check all the valves. It is not one for a long-term oxygen therapy. Any issue with the valves can make the CO2 build up. And it is usually with higher flow rates, the patient feels a bit of suffocation and it is uncomfortable to the patient. Next. So this is how a non-rebreathing mask with a reservoir bag on the right side and the reservoir bag in a partial rebreathing system. Just look at the valves. There is no valve in the partial rebreathing system, whereas there is valves in the non-rebreathing system. So that is the difference, and these valves close while exhalation. That is why the exhaled air goes out, and during inspiration, all the air from the reservoir bag is taken into by the patient, which gives a higher concentration of oxygen. Next, please. So venturi mask, you should all know about venturi mask. It is a high flow oxygen delivery device. When we talk about high flow, it means that the patient's inspiratory flow demands are met by the flow with this device. So oxygen is given by the 40 to 50% and the flow rates are 4 to 15 liters per minute. The mask is constructed in a way so that there is constant flow of room air blended with the oxygen fixed concentration. So venturi principle is very important. And next slide, please. So it is color coded. It is written what is the flow that should be there, what is the FiO2 that the device or venturi mask is being provided. It is color coded jet adapters, and you give a certain amount of air through the pipeline, and then other air is entrained from the room air, and the both of the air mixes, and the FiO2 is decided. So you should, when you use a particular venturi, you should also start it at a particular flow rate. And with the holes or with the deviations or holes in the venturi principle, the air is entrained, and in each color coded, a precise amount of oxygen at a specific flow rate is given to the patient. So when you want to titrate the FiO2 that you want to give, so like in a COPD patient or a hypercapnic respiratory failure patient, you want to titrate the amount of oxygen that you give to the patient. You want to maintain a saturation of around 90-92% only. So in those patients, venturi principle or venturi mask is the best thing that can be used. Next. So the advantage is it delivers most precise oxygen concentration and doesn't dry the mucous membrane because of low flow rates. And again, it is uncomfortable because it covers the face and the mouth and the nose. And there is a risk of skin irritation at higher flow rates. Next. So a newer device that has come in vogue nowadays, high flow nasal cannula. So benefit is that we are seeing that all of the previous devices are causing a bit of dryness or irritation. That is because the air that is being provided is not humidified. With HFNC, the benefit is that we provide heated, humidified, titrable oxygen therapy. And the flows can be increased independent of the FiO2 or the oxygen level. And the beauty is that when we give a certain flow, each 10 liters of flow gives a pressure of around 0.7 centimeters of water. So when we set a flow of around 50 liters per minute, it will give a PEEP effect of around 3.5. So 5 into 0.7 roundabout. And this PEEP is more reliable if the patient breathes with a closed mouth. So since it is attached to the nose or the nares, if the patient opens his mouth, the PEEP effect is lost, and the patient breathes with a closed mouth, the PEEP effect is more reliable. The components are active humidifier, heated inspiratory circuit, a nasal cannula, a flow meter, and an air oxygen blender. Next, please. So we should note that the nasal cannula are soft and pliable. Next slide, please. So these are the benefits and the mechanisms. It's very important you to go through this when you use the HFNC. Now it is being routinely very commonly. So it gives the heated and the humidified air. So that will help in decreased work of breathing, avoids airway desiccation, enhance patient comfort. The small pliable nasal prongs are in 2-3 sizes which are available. It again enhances the patient comfort. So there the whole face is not covered, only the cannulas are there in the nose. And improved ventilation oxygen delivery is there. There is washout of nasopharyngeal dead space with the high flow rates. And as I told you, there is a PEEP effect given to the patient of around 2 to 5 centimeters of water, which again decreases the work of breathing and makes the patient more comfortable. Next slide, please. The benefits are improved oxygenation, decreased anatomic dead space owing to washout of upper airway, improved work of breathing, and better secretion clearance, superior comfort. So this is very important when you give heated and humidified air to the patient. Suppose you have to do it for certain days. When you give a dry air and as you compare to give a heated and humidified air, the patient is much more comfortable. There is better secretion clearance. The patient will not feel any dryness. So this is very important. So when you use the HFNC, try and see that the humidifier water level is also at the correct space, please. Next slide. So Ambu bag, artificial manual breathing unit or bag, gives it's a handheld device. If you must have all seen, it has got 3-4 valves. There's a bag, and then there is a high pressure valve. It can be attached to any face mask. You can see on the right side there is a face mask. There is a tubing. You attach it, the ambu bag with a tubing to the flow meter, open it to 15 liters per minute, and there is a reservoir bag attached to it, which should always be full. So it can artificially give breath to the patient. We have to hold the face mask in a CE technique and give breath to the patient and look for visible chest rise when you give breath to patient. And always connect oxygen, always open the flow rate to 15 liters per minute. Always check the reservoir bag is full. So this will give you or deliver a higher concentration of oxygen. Next, please. Coming back to our case, we tried initially non-rebreathing mask, then HFNC, the saturation tried to initially improve, but by day 3 it started to worsen. There was increased work of breathing and fatigue. With HFNC FiO2 of even 100% or 1, the PO2 was less. And the patient was finally intubated and mechanically ventilated. Lung protective ventilation strategy was given. And this patient had hypoxemic respiratory failure. When we did a classification of severe ARDS, the PFH was less than 100. So it came out to be a severe ARDS patient. Yeah. Next. So when you talk about respiratory failure, it is defined as a PO2 of less than 60 and or PaCO2 of more than 50 millimeters of mercury. So hypoxemia and or hypercapnia, and this is defined when the patient is on room air. That is a FiO2 of 0.21. Next. So these are the types of respiratory failure. Initially they were hypoxemic and hypercapnic, but in the last decade, the type 3 and type 4 have been explained. So initially in the hypoxemic respiratory failure, you can see the common causes like ARDS, pneumonia, pulmonary edema, and pulmonary embolism. And the ABG's pattern is decreased PO2, where the PaCO2 can be normal or decreased. When we talk about hypercapnic respiratory failure, it can be due to drug overdoses. The patient ventilator drive can be decreased. There can be a neuromuscular disease. The patient is unable to take the adequate amount of tidal volume, or the patient may suffer from COPD. So PaO2 is also less and the PaCO2 is also increased. The type 3 is perioperative or respiratory failure, which is atelectasis-related hypoxemia post-op, which is mostly in the abdominal and thoracic injuries or surgeries. Then there is shock-related respiratory failure. So in septic shock and cardiogenic shock, this shock-related respiratory failure is being defined, which is respiratory muscles fail to act in a proper way due to hypoperfusion due to the shock. So most common is the type 1 and type 2, and we'll be talking about that. Next slide. So then another question is what PF ratio or what PA2 by FO2 ratio defines severe ARDS for Berlin criteria? Anyone? Can we have the answer? So PF ratio is less than 100 in severe ARDS. Yeah, next slide. Next slide. This is the Berlin definition. The mild ARDS was PF ratio between 200 to 300, moderate is between 100 to 200, and severe is less than 100. Next. So we'll talk about hypercapnic respiratory failure first. So these are the causes. It can be to a neuromuscular disease like myasthenia gravis, Guillain-Barré syndrome, or spinal cord injury. It can be due to airway disease like COPD and asthma, which very commonly come to us. There can be central depression, opioid overdose, sedatives overdose, or head trauma. Then chest wall defects. So these are all called hypercapnic respiratory failure. So as the name suggests, along with decreased oxygen, there is increase in the carbon dioxide levels when you do a blood gas analysis at room air. Yeah. Next. So when the patient presents to hypercapnic respiratory failure, which is the most common cause? Pulmonary embolism, COPD exacerbation, ARDS, or sepsis-induced hypoxia. A very easy one. Anyone? Can we have the answer, please? Next slide. Next slide, please. Yeah, COPD exacerbation. So most common cause of hypercapnic respiratory failure in the ICU setting is COPD exacerbation. Next. So I want to talk about non-invasive ventilation in a COPD patient or a obstructive sleep apnea patient or in a patient who's having neuromuscular disease. This is the first line treatment. So it is a first line treatment using in a stable conscious patient, And the preferred mode is a bilevel positive airway pressure. So we should know about the two levels that we set. First is the expiratory positive airway pressure, commonly called as EPAP, which is a surrogate of PEEP, and this improves the oxygenation. And then the IPAP. IPAP is the inspiratory positive airway pressure. And the difference between IPAP and EPAP helps us to determine the minute ventilation and helps remove the carbon dioxide levels. So especially in patients of type 2 respiratory failure or hypercapnic respiratory failure, NIV is being used. Other indication of NIV is cardiogenic pulmonary edema. And in patients of palliative care who do not want to get intubated. So there are different indications of NIV. But when you, at least especially for my nursing colleagues, when you put a patient on NIV, you should hold the NIV initially in your own hand. Talk to the patient, make him comfortable because there's a high pressure, the patient may be claustrophobic. Start with lower pressures and over the next 30-40 minutes, try to improve to the level of pressure that you want to set. Always set a EPAP for at least 4. The difference between IPAP and EPAP should be at least 4. So 8/4 is the minimum setting that we set. And we talk to the patient, we try to explain to the patient, and initially do not strap to it. Initially hold it by your own hands. And after the patient is being comfortable, then only strap it to the patient. Next slide. So again a question, which of the following patients is NIV the most appropriate? So comatose patient with GCS less than 5, alert COPD patient with PA 7.28, PCO2 65, or respiratory of 30, patient vomiting continuously with facial trauma, or a hypoventilating drug overdose patient with GCS less than 6. So when we talk about NIV, it is very essential that we have a patient who is alert and cooperative. He should have a GCS, adequate GCS of at least 13, 14, 15. He should be responding to your commands. He should be alert. He should be cooperative. The patient should not be vomiting. The patient should not have facial trauma, so that you can apply the NIV mask easily on the patient. It is usually the mask that is used, the oronasal mask. So oronasal mask, like a face mask, and it has what a soft pliable thing that is touching the face, but increased pressure because the flow of air is definitely there. So you have to have a patient who is very cooperative in this case. The answer, please. So the correct answer is the patient should be alert COPD patient with PA 7.28, PCO2 is high at 65, and respiratory of 30. Next, please. Next. As I told you, NIV is best used in a cooperative conscious patient with hypercapnic respiratory failure, and the contraindications include altered mental status, vomiting, and facial trauma. Next. So when should a patient be intubated in hypercapnic respiratory failure? So when you have a patient who is having increased CO2, you apply NIV, try to monitor the patient. And if his GCS goes down, serially monitor the blood gas analysis. If the patient has a severe, the acidosis worsens, so this is the patient you might have to intubate. So in this case, the correct answer is if the NIV fails or the patient deteriorates, that is GCS moves to less than 8, which is an indication for intubation, and the pH also deteriorates. Yeah. Next. Next slide. So now we come to the ARDS pathophysiology, which is a typical of hypoxemic respiratory failure, and this concept is the baby lung concept, which was given way back around 2 decades back from 2025. It tells you that the amount of lung that is there in the patient, like we have a certain amount of lung, and when the patient is having ARDS pathophysiology, ARDS is a syndrome which is caused by multiple diseases. The amount of lung which is taking part in the gas exchange decreases, and that is why it's being called a baby lung concept. Next. So this told us that the amount of lung which is used in physiological air exchange decreases. Next, please. And when we talk about ARDS pathophysiology, it has three phases. First phase is 7 days, second is 7 to 14 or 21 days, and third is the fibrotic phase. So in which phase the patient comes to you, you can do certain amount of things that will help your patient. Usually the patient presents in the first 7 days. Initially, the next slide please. Initially the patient is managed with simple supplementation of oxygen, and when the oxygen is not enough to supplement him with a HFNC or NIV, and the patient deteriorates, you might have to intubate a patient, like in our patient. Next slide. In our patient who had severe ARDS, this patient had to be intubated because the PF ratio was less than 100. Next slide. So, how do we manage such a patient? Next, please. So again, telling you that the initiating agent in ARDS can be any. This patient, the patient that came to us had a fever and a cough. This patient probably had a kind of pneumonia, but there are multiple causes of ARDS. Next slide. There are intrapulmonary causes with direct lung injury, and there are extrapulmonary causes. So if you see on the left side, the direct lung injury or the pulmonary causes include pneumonia, there is aspiration of gastric contents, pulmonary contusion when you have a trauma patient, and toxic inhalation injury, which can directly affect the lungs. When you talk about indirect lung injuries, two most common things that we deal are severe trauma, sepsis, and pancreatitis. These are the patients who come to us with the indirect lung injury. Next. So both kind of lung injuries behave in a different way. So when you have a patient, you should try to distinguish between the two types of ARDS, the pulmonary and the extrapulmonary ARDS at least. Next. So extrapulmonary ARDS tends to be more homogeneous. When the cause is of pneumonia, you can see that the X-ray, left or right side will be more affected. But when the patient is having maybe a pancreatitis-induced ARDS or a sepsis-induced ARDS, both the lungs are similar or homogeneous. Next. And when we talk about recruitment, extrapulmonary ARDS has better potential to respond to PEEP and recruitment. Next. So initially, when the patient came to us, we initially a decade back, if you ask me, we used to do recruitment strategies, but because of the side effects, we don't do it nowadays. When the patient comes to us with severe hypoxia with respiratory failure and is not improving, we try to first give prone ventilation to a patient. So we make him lie upside down. The patient is supine, but we give prone ventilation. So when we talk about prone ventilation, as my nursing colleagues, you should all know what is prone ventilation, why is it important, what do we have to look for it, and how do we prone a patient actually. So firstly, we should know in which patients we should prone. A severely hypoxemic respiratory failure requiring very high oxygen concentration coming in the first week of ARDS. So we give a prone ventilation trial of at least 16 hours per day. We give up to 3 to 5 therapies routinely. And in these types of patients should be deeply sedated and at times paralyzed. The aim is to improve the oxygenation of the patient. Next. So when we talk about proning a patient, in this patient, injection fentanyl and atracurium was given. We discussed with the primary team and the family of the patient. And when we prone the patient, firstly, we should look that the patient should be hemodynamically stable. Second is that the patient, when we prone, we should look at the parameters that we EtCO2, the hemodynamics, they should not worsen. There should not be a sudden rise of the end-tidal carbon dioxide. There should not be a sudden drop of oxygenation. And we obviously do a blood gas analysis serially after at least after 1 hour of proning or maybe 30 minutes of proning, and then another after a few hours to see whether the patient is getting better because of proning or not. Next slide. So we do supine. After 16 hours of proning, we supine the patient and then we see whether the patient's, the positive effects that we got in proning, that is what can be the positive effects? Increased PO2 levels and decreased FiO2 levels are the two positive effects, and they should be carrying on when we make the patient supine. And then we realize that we do want to do a second or a third or a fourth proning session in this patient. Usually do end up doing 3 to 5 proning sessions. So we should know how to prone the patient. We should how to know how to hold the endotracheal tube, how to prone in a way that the patient's IV access, the central venous lines, the Foley's catheter, the endotracheal tube should not be dislodged. Then the patient can be having pressure sores. So what are the areas that we actually need to put pillows so that the patient does not develop sores, because this patient is paralyzed and he is on our mercy for the next few hours. He cannot move. He is deeply sedated. So we have to take care of this patient. And I told you we have to monitor the patient extensively when the patient is prone, and we should know when to raise an alarm. Next slide. We should do a serial X-ray when the patient is again made supine. We do a X-ray. Next. So should be instituted early. When we have a patient of severe hypoxemic respiratory failure, we should do it as soon as possible, as soon as the patient becomes hemodynamically stable. Next. So in our patient, despite optimal prone ventilation, PEEP, and neuromuscular blockade, the patient did not improve, and we realized we have to do a veno-venous ECMO. So that is the last resort nowadays. Next slide, please. So there are two types of ECMO, VA ECMO and veno-venous ECMO. The veno-venous ECMO tries to supplement the lungs. The arterial ECMO tries to supplement the lungs as well as the heart. Next. So this is what is ECMO. It's extracorporeal membrane oxygenation. It is a mechanical cardiopulmonary support. So it is just like a bypass, it's long. Here what happens, venous blood is drained through a major vein. So it's usually taken out through the femoral vein, and there is an oxygenator and the pump, and then there's a temperature thing that is maintained when the blood is outside. That is by what we mean by extracorporeal, that means outside the body. And then we pump in the blood through the jugular cannula normally. Next. This is how it looks like. So femorally taken, jugulary given, and that is why when after the oxygenator, when we give it back to the patient in the jugular vein, this is the bright blood which is oxygenated, and carbon dioxide is removed. And because the patient is outside the body, we need a pump to circulate the blood, and we need a heat exchanger to maintain the temperature. So this is the basic configuration of the patient with a VV ECMO. Next. So this is how we try to manage a patient of a refractory or a hypoxemic respiratory failure. So initially we give him lung protective ventilation, that is we maintain tidal volume of 6 ml per kg per body weight and try to maintain a plateau pressure of less than 30 centimeters of water. And PEEP should be maintained at least 5. In some patients we have to go up to 10, 12. But these patients should be deeply sedated. If the patient is not responding to this, we try to do a prone ventilation trial for these patients. And while we're doing a prone ventilation trial, we should be very, very careful what we monitor and what are the side effects. So the patient should be deeply sedated. The patient should be monitored for barotrauma. We should monitor the peak pressure on the ventilators. We should monitor the hemodynamics, then tidal carbon dioxide, and for the pressure source. If the prone ventilation, we make the patient supine, and during supine, we check again for the blood gas analysis. If the patient is being maintaining well, we might even do 1 or 2 proning sessions. Sometimes we have to give up to 3 to 5 proning sessions. And if the patient is not improving on prone ventilation, we have to move to veno-venous ECMO. Yeah, thank you. Next slide. So to summarize the key intervention in patients of hypoxemia and respiratory failure in ICU, first is oxygen therapy, which can move from nasal cannula to a non-breathing mask. If you want to give a specific oxygen, we can use a venturi mask. If the patient runs prolonged, it is high HFNC, which gives heated humidified air, a bit of PEEP effect to decrease the work of breathing, and the patient is much more comfortable because he can eat also along with the HFNC. Then we should be particularly knowing that when we need to mechanically ventilate or intubate a patient, and how do we move to a prone ventilation. And the last resort is VV ECMO if the patient is having refractory hypoxemia. So that is a complete field in itself. Yeah. Next, please. So thank you so much. That was all about hypoxia, and respiratory failure in ICU. So can we have the questions on the chat box?
Yeah. Thank you, Dr. Saurabh. It was a very comprehensive talk, and you have covered everything right from oxygen therapy to VBA ECMO. And see, as a critical care nursing staff, you must be able to identify patients who are having acute respiratory failure, because it is very often we see in our ICUs that the patient will have some kind of respiratory failure. So if the patient is not breathing properly, or patient is having slow breaths, or patient is very tachypneic, so all these things can indicate that the patient is having some kind of respiratory distress or some respiratory problem, and you need to escalate it. Obviously, the adjuncts, the monitoring, the saturation, looking at the saturation is the sixth vital in our ICU. So when the patient is in the ICU, you look at the oxygen saturation, the oxygen saturation is dropping, or it has, even if it has come down from 100% to 92, 93, that is also a significant drop. So any drop in more than 10% should raise your concerns. Or if it is dropped below 90%, then obviously you should be aware that there is a problem, ongoing problem, and you need to highlight it to the attending doctor over there. And tachypnea has been identified as the single most important parameter for recognizing acute illness. So if the patient is tachypneic, respiratory rate above 22, then you should definitely think that there is some problem with the patient and you must look into it. So if you have got any questions, you can just put it in the chat box. We will be happy to take those questions. Since there are no questions, I think this brings us to the end of today's session. Thank you, Dr. Saurabh, once again for joining us today. And I would like to thank the ISCCM staff also for organizing this session. Thank you all. And
Thank you,
thank you
Dr.
all for
Deven.
joining us
Thank you,
today.
ICCM. And thank you, the coordinators that make it possible every week in day and night.